Good afternoon, everyone, and thank you for joining us at the very first session of the Recovery Science Echo, brought to you by BWell Texas and the Center for Substance Use Training and Telementoring, CSTAT. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick housekeeping notes before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, click on the speech bubble icon at the bottom left of your Zoom controls. To all the BWell Texas providers, please make sure that you identify yourselves during the session by entering your information into the chat, or if you're joining by phone, please email your phone number and name to bwelltx@ithaca.edu. We encourage everyone to join by video for the discussion portion of the session in the latter half. That said, regardless of how you join, we are just happy you're here to learn alongside us. We are recording these sessions for later distribution through the BWell YouTube channel. Any info you put in the chat will not be shared in these recordings. Please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, please, your mute button is on the bottom left of your Zoom controls. And if you're on the phone, just press *6 to unmute. You can also use the emotions menu at the bottom right of your Zoom screen to raise your hand and indicate you have a comment to share. Or you can use the chat to share your perspective. There's a lot of us in this space, so please keep your comments brief to allow others a chance to share as well. And finally, please note that no protected health information is allowed in either the chat or the discussions. Towards the end of the session, the BWell Texas team will send out a link to an evaluation survey. Please fill it out for a few reasons. It gives us your feedback on how to refine and shape these sessions to address your priorities, and it allows you to access free continuing education credits. This is a unique series, and although we are offering CMEs today, we would like to hear from you, the participants, on what type of CMEs you are interested in receiving during these sessions. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. For those who may be new to ECHO, welcome. It stands for Extension for Community Health Outcomes. This is a model of lifelong learning and guided practice that connects community-based healthcare workers with each other and a multidisciplinary team of subject matter experts to create a community of practice and learning. The model was developed by a liver disease specialist about 20 years ago to support primary care physicians in delivering life-saving on-site treatment for hepatitis C virus to uninsured or underserved patients. It rests on a simple realization that you can move knowledge instead of moving people. And if you do that enough, you improve access, support the growth of the health workforce, and transform community health. A couple of things about the space: ECHOs thrive on conversations that acknowledge and include the perspectives of many. So we welcome your questions, your experiences, and your perspective in all of our discussions. And remember, we are all learners and we're all teachers in this space, so your contribution matters. We'll follow a pretty standard structure for these sessions, starting with introductions of the hub team, and then a brief evidence-based didactic on a key topic related to recovery science considerations in the SUD space. Following that, a member of this learning community will present a case using a structured form developed for this ECHO, highlighting questions they might have for this group. Then we will discuss the case as a group. This is really the heart of the all teach, all learn model of ECHO, and the space for you to share your challenges, strategies, resources, and lessons learned with your peers and colleagues. Then we'll wrap up with a quick summary of key recommendations by a member of our hub team. With that, we're going to start with some introductions. We'll begin with Dr. Ashford.
Thank you very much. Morning or afternoon, everybody, depending on where you're at. I guess it's afternoon for most people, unless you're on the West Coast. But Dr. Robert Ashford, if I don't know you, it's a pleasure to meet you, and thanks for joining our inaugural session. I'm one of the co-Is on the Peer Recovery Innovation Network, which we're going to talk about some today. That's where this Recovery Science Echo comes out of. And I'm joined by various colleagues that make up the hub, as well as all of y'all, and look forward to getting to know you and over the next coming months.
Thank you so much. Dr. Hennessy.
Hi, everybody. I'm Emily Hennessy. I'm Associate Director of Biostatistics at the Recovery Research Institute, and also Assistant Professor at Harvard Medical School. So it's lovely to be here with you all.
Thank you so much for joining us. Dr. Costado de Martel.
Hi, I'm Sierra Costado de Martel. I'm a postdoctoral researcher at Chestnut Health System's Lighthouse Institute. I'm a person in long-term recovery. I worked in collegiate recovery before transitioning into research, and my research focuses on peer recovery support services, the workforce, and the economic evaluation side.
Thank you so much for joining us. Cheryl Pacapelli.
Hi, everybody. I'm Cheryl Pacapelli, person in long-term recovery, also from New Hampshire, project director for Harbor Care, overseeing the recovery community network in New Hampshire.
Thank you so much for joining us. Dr. Adrienne Lindsay.
Hi, everyone. Adrienne Lindsay at UT Health San Antonio. I direct our Center for Substance Use Training and Telementoring. I recognize some of you from our broader ECHO community, and we're just really excited to launch our first research-focused ECHO. So thanks for being here.
Thank you so much. Julie Parsh.
Hi, everyone. I'm Julie.
You're muted, Julie.
Sorry about that. Hi, everyone. I'm Julie Parrish. I'm the ECHO Program Manager at the Center for Substance Use and Training and Telementoring at UT South San Antonio. I'm excited to join you all. Thanks so much.
Thank you so much. Daniela Almos.
Hi, everyone. Pleasure to see you all here. I'm Daniela. I'm the project manager for PRIN. I work closely with Dr. Ashford. And just really excited to kind of get this started as part of the Peer Recovery Innovation Network. So thank you so much for joining.
Thank you so much. Andrea Hebler.
Hello, everyone. My name is Andrea Hebler, and I'm one of the program coordinators here at CSTAT. Thank you and welcome, everybody.
Thank you so much. Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal. I'm one of the program coordinators here at CSTAT. Thank you for joining our session today and hope you enjoyed today's session.
Thank you. And with that, we will begin our didactic. Dr. Ashford, you can take it away whenever you're ready.
Thank you very much. All right, slides are coming through. No tech issues today? Perfect. Minimize y'all. So once again, thank you all for joining our inaugural and kickoff of this new research-focused ECHO. And we've got a lot of different things to talk about. I will say some of these slides I may go through faster rather than slower. They tend to be built up, so when you get copies of them afterwards, you may be able to parse through them on your own speed. But our goals today are really to talk about a couple of different things. One is to as this first ECHO, is to set the context of how we're viewing concepts such as recovery and recovery science, where a lot of this work is happening, or at least the most common in terms of RCOs. And some of the laying that groundwork for what this ECHO is going to become over the next couple of years before we get into our case study. We will spend some time at the end talking about the Peer Recovery Innovation Network, which is the NIDA R24, one of the CORES projects that is funding this ECHO and other work. So lots of different things to cover, and hopefully we'll get to learn some. We'll have some time for some questions at the end. I will say, if you've never been a part of an ECHO, or if you don't know me, I want everybody to take just a deep breath. I like to be a little more informal. We're just going to have some learning and some fun. Stakes are low. So let's get to it. So if you don't know me, I know many of you looking at your names, but I am a macro social worker and recovery scientist. I have a PhD in health policy with a focus on behavioral health, primarily in digital recovery support networks. I do have the pleasure of also being a director of a Unity Recovery, which is an RCO in Philadelphia, now in Pittsburgh and in Weatherford, Texas as well. So not only researching this work, but also impacted by it and get to do it in practice every day with a great team. As I mentioned, I'm one of the co-principal investigators on the PRIN. I am a person in long-term recovery. So this is also very personal to me. Bring that into everything and all the work that I do. Starting 10 years ago as a recovery coach in Texas, and now as a researcher and recovery scientist and much more. And my actions didn't work, so have gotten to see her, but I'm also a dad. My wonderful daughter, Penelope, who's now 4 years old, which brings a whole bunch of new meaning to the work that I get to do day in and day out. And I will say, even if you're not in the Metroplex, go Rangers. Hopefully we'll see it in Philly so I can go to a game up here. And that was from Penny's first game, which she had a blast at. So as a background and priorities, and we talk about this, right? And I have a bunch of them. You know, the field of recovery science and all of its different intersections is in its relative infancy. So there's a lot of things that I have empirical interest in. And some of those things that informs the work that we do and how we try to apply this framework of recovery scientists are in a lot of areas that many of you probably know. So recovery support institutions, ROSCs, or recovery-oriented systems of care. A lot of my early research was around linguistics or language, labels, and its intersection and interplay with stigma and discrimination as it applies to our communities and milieus. Pharmacotherapies or medications for different substance use disorders. Machine learning and predictive analytics as applied to digital recovery support services. Harm reduction services, CRPs and recovery high schools. Health communication and health literacy, so how we actually communicate and get people to understand and take action on some of the work that we're talking about and will talk about over the coming years. And then more recently, over the last couple of years, which has only grown since the COVID-19 pandemic, the construct of digital recovery support services and social networking, as well as more recently, virtual recovery support services and virtual reality, not just in 2D screens. So as I mentioned, as we start this, right, I think it's important not only to set the bedrock of recovery science, which we'll talk about in a moment. Maybe you've never heard that term before, but before we even get there, we have to at least get on a similar page of what do we mean when we talk about recovery, both from Pren's perspective and broadly in everything you're going to hear from me today. And as many of you that have been in the field for a very long time, recovery has been defined in various different ways by various different stakeholder groups. Many of you probably still use SAMHSA's working definition of recovery. I will say back in 2017 and 2018, there's a group of budding recovery scientists, as well as traditional addiction scientists that came together and say, how do we operationalize and define recovery for our purposes within this construct of research that really needs to grow, and it's its own body of research. And this predates even our concepts and work on recovery science as a field. And what that came down to is defining recovery in this way, that recovery is an individualized, intentional, and dynamic and relational process involving sustained efforts to improve wellness. So every time that I say recovery, at least today, you know where I'm coming from. And the idea behind this, as we worked within this collaboratory stakeholder group for the RSRC, was not only to help it operationalize it for research, because we were seeing more recovery research starting to really happen in force in 2016 and on. It's only continued to increase now. But also, I mean, science is political, science is advocacy, and that's a lot of our frameworks and backgrounds have come from that space as well, including with our lived experience, at least for me. So we wanted to make sure that it also included some of the central tenets that were important from previous definitions and what we were beginning to understand. So you'll notice as you read this is inclusive, big tent type of definition. So it does include both mental health concerns as well as substance use. The idea was to help preclude discrimination resulting from individuals that were using or do use dynamic and different pathways and programs of and to recovery. And it's, whether we agree with that or not, it can be operationalized in different ways. But again, the importance here is we can ask all of you 60 on the room, and we would probably still get 60 different definitions of recovery, and that's fine. But at least from a research perspective, how can we begin to work from a level set playing field so that we know what we mean? Right, and it's okay if we don't have true consensus. Not every activity needs to have consensus across all of it, but we can begin to think around this definition of recovery for our primary purposes, whether those are research, whether they are policy, whether it's larger public health. And if we break all of that down, right, and if you're in recovery support services like I am, I noticed many peers on the call as well, they begin to see some of those central tenets coming into this definition too, right? This amalgamation of both sides of the field being represented. And it's ideally that recovery is an individualized process in the same way it can be defined individually, like we would get 60 different definitions, and it's a self-directed process. But that doesn't preclude that certain characteristics related to outcomes related to recovery can't be necessarily applied to general populations. It can, it doesn't prevent that from happening. It also allows us to really truly understand within these parameters that recovery is never linear, right? It's not a linear progression, nor is it time limited. It crosses those bounds on both sides. We also know that recovery can begin through these various different access points and then progress over time through a variety, and these are only continuing to grow, pathways and programs and services, and they never have to stay static, right? Recovery doesn't look the same for me almost 11 years into it as it did in year one. It's changed a variety of times over the last 11 years. And we're beginning to understand that and truly operationalize it and study it is important because we know it happens. And finally, it's this idea that no matter how it's initiated, no matter how it progresses, where it's most likely to flourish and be sustained or maintained is likely to happen in some type of community, which can be broadly defined as whether those are identity and characteristic communities, whether they're physical bounds or geographic, where do you actually live, social communities, digital communities. Community means a lot of different things. It's not always our physical presence. So if we move past thinking around what do we actually mean, in this case, the we collective we of me in this Echo and Pren, it also is important of who are we talking about and how can we characterize them at a high level. We know many people in recovery, but it's important from a research perspective. What does it look like nationally? And thankfully, we have some great research from the National Recovery Study that came from some great recovery scientists and researchers out of the Recovery Research Institute, Dr. John Kelly and others. So we can begin to set that context as well, right? So previously, prior to this research, we used some different outcomes tools that were done by Favor and some consultants. You know, the idea, you probably heard it before, the 23 million Americans living in recovery. We have some, thanks to this study, a little more rigor in terms of finding the same outcome, or at least broadly the same outcome, but something that's more than just some phone trees that a consultant may have done. And it found that about 9% of the US population has resolved an alcohol or drug problem in the past, right? So it's important to even think of when we say here, this is specific to substance use. We know there's probably another 10 to 13% in resolved mental health concern or mental health recovery. And if we think about these people, right, specific in substance use for the sake of this conversation in Pren, about half of those self-identified as a person in recovery, right, that would hold that moniker, because it's different than saying I've resolved a past issue with substance use and actually self-labeling as I am a person in recovery, even if they share similar characteristics. Over half of these reported resolution via an assisted pathway, right? So this is the lifetime use of some formal support mechanism. So when you hear people talk about natural recovery, for instance, they may have high human capital or high intrinsic recovery capital if you're in the field and have heard that term. And some people self-recover without any use of these formal things, but a plurality, or at least about 54%, have reported resolution via at least assistance with these formal support mechanisms. Which on the inverse, if you're thinking about it, also means that about 50 or 46% did not. And again, this is somewhat in line with previous prevalence studies or quasi-studies looking at about 9 to 10%, or about 22.35 million, right? So it's important as this is who we're talking about. And as we look deeper into this, because it has to inform our work and how we conceptualize it, and it's probably is not a surprise to many, but perhaps it is not all who resolve what we would consider past substance use disorders of varying acuities are completely abstinent. Of those that identify in recovery, meaning self-labeling, about 60% are completely abstinent. 17% are only abstinent from what they would identify as their most problematic substance. And 24% or a little less weren't abstinent at all, right? But would still hold that label. And that tells us a lot about who, when we start talking about people in recovery, about the services that we want to research or programs that we want to evaluate, we got to, who are they serving and who are the people that we're actually talking to? Because it's not just a monolith. Recovery, in similar to our definitions and being nuanced and diverse, the people we're talking about are as well. And you might think that it would be wildly different for those, maybe they don't hold the label or used to self-label as in recovery. And there's maybe some reason, and there are some differences. They're not as perhaps widespread as you might think, but of those not self-labeling or considering themselves a person in recovery, about 46% are completely abstinent, 25% or so only abstinent from that most problematic substance as identified, and about 30% not abstinent at all. So we have a wide array, this community, if you will, the organized recovery community, the inorganized recovery community, these people that have these experiences, again, are not the same, nor should they be. So as we talk about research and program design, et cetera, it's got to encompass policy, appropriations, all of these things are much broader than what we might just consider traditional people in recovery that are focused on substance use and not using it anymore. It's not that simple. So what does all of that mean if we piece it all together and the TLDR of it all? So we have these, national epidemiological studies have shown that recovery is nuanced and individualized processes are likely to occur across a variety of pathways and initiation points. There's no wrong way to proceed towards wellness. We also know and can take away from this that recovery has to include, by definition, abstinence, partial abstinence, and no abstinence as key characteristics of that label and that construct. Which also means, and it bears even in 2023 to say it and say it loudly, that recovery defined by abstinence only is an incomplete picture and discounts the lived experiences of millions of people at this point. So it's not just, from my perspective, ethically wrong to do that, it's also empirically wrong to do it. And finally, the big takeaway there is, because we have to contend with it, and what does it mean and how do we recreate it perhaps in other settings, is that many Americans, at least in this study, naturally recover without any formal recovery supports or treatment supports. This idea of naturally spontaneous recovering, which is a bit of a misnomer because they likely have higher intrinsic social support, social capital, or recovery capital, but we need to know more, right? And it's, again, it begins to be a much more complex picture as we begin to define what recovery looks like in the US. So with that platform kind of setting the stage, right, of here's how we define recovery, here's what we think recovery looks like in the United States, at least broadly, begins to point into the other part of this echo, right? It's all about recovery, absolutely, everything we do is, but recovery science is the specific element of this as we continue to grow this kind of burgeoning field. So as we think about recovery, for many of you that are practitioners or perhaps emerging scientists, existing scientists in different fields, historically, recovery has been seen as personal identity and also an organizing paradigm for policy and systems of care, otherwise known as recovery-oriented systems of care. And it has to begin to broaden, right, of both practice and advocacy, certainly, but also our research agenda. And if we take key learnings from both people in recovery and the services that have been provided for millennia and more recently in the last 2 decades in an organized way in the form of formal recovery support services, we can learn a lot from that. We can actually tie that to our research and practice in different elements. This idea of co-equal power dynamics are close to it. Individuals are the experts in their lives, meaning they can also perhaps be experts within research about their experiences in their lives. And if we take this, right, if we, rather than science for science sakes, but really put recovery at the center of empirical inquiry, right, at least in the Western sense of empiricism, if it's an inherently strengths-based approach and recovery naturally focuses on the individual and the community, it allows the same things to manifest within our research agendas and our research practices, which is a far sight different than we might consider historic science in a similar domain or addiction science, which doesn't really do that. And if we look across the last 100 years, right, addiction is a primary and secondary pathology. It's pretty well studied, right? There's certainly always more to examine empirically, but we have more research than not around what we consider like severe substance use disorders or addiction. Most science in our space has largely come from that framework or that as the primary goal of inquiry. But how people get well differs from how they get sick. And I think we have to understand that as a true premise, right? And the absence of specific symptoms or the presence of things like percent days abstinent or just abstinent writ large isn't by in and of itself an indicator of recovery or health and wellness or growth, at least by itself. It could certainly, if defined by the individual as important, can be, but that as a benchmark and gold standard doesn't particularly work as we think about recovery as we just talked about. And if we take that an even further lens of how we defined it and we think about recovery, this engine of recovery, right? The idea of how wellness happens and manifests, it's really across sometimes behavioral health related, so substance use and mental health, but also non-behavioral health related life spheres, right? The idea of things like, if you think of recovery capital, employment, housing, social determinant categories, it's all of those things combined where we begin to see the manifestation of healing in some forms or fashion, right? And because of that, we also know that it's inherently interdisciplinary, right? Just like a ROS, we need several different stakeholders, several different fields of study, several different ways of thinking and theory, all working together, because we can't just have one type of professional group or one type of researcher doing this, because that's not how recovery is served, nor how it happens in life. So it inherently has to include that multi-stakeholder group. And if we listen to people that identify as in recovery, right, it's not an endpoint, it's not an outcome by itself. It can be, but it's much more than that. It's much broad. It's whether it's a label, whether it's a Identity, whether it's a lifestyle, it can also be a primary endpoint or an outcome, but it's much, much more than that if we listen to people who believe they've recovered. Right, and if we think of this broader field, especially over the last 20 years, as I mentioned, we think of these recent innovations in the space, formal recovery support services at various different settings. They deserve to be evaluated in a more appropriate manner, right? That recovery is the central organizing paradigm rather than the pathology or the addiction or mental health concern. That it's the same way we deliver services, these programs deserve to be evaluated with the same underlying approach. Which leads to this construct of recovery science. So one of the, as this field is really blossomed, we've defined it and tried to do work in it, both from the recovery science research collaboration and otherwise. We came through this initial point of, we need a grand theory that really begins to posit how we're going to do this work. How are we going to apply it to research, practice, et cetera? And recovery-informed theory that Austin and I wrote about in 2018, it attempts to do some of that, an organizing paradigm. And the idea is that successful long-term recovery is self-evident, and it's a fundamentally emancipatory process, which just is really a fancy way of saying we can see it, and it's a freeing and healing process for people that engage in it. And if you think of those as in terms of key points, right, it takes the idea of how people recover, their trajectories in life, as where we should explore recovery science as the lab, right, instead of as in some ivory tower. It also prevents us from having to prove that recovery happens. We know recovery happens. There's millions of people that can tell us to it. They are the evidence of that. It's self-evident because we see it every single day. It's no longer, we can certainly prove and ask questions about does something work, but we no longer have to prove recovery from this framework. And it allows recovery to be just what it is, to be authentic. And it's a phenomenon that is not well understood at this point, but it does occur. And we can begin to understand it more outside of just saying this happens. And I think most important for me as a person in recovery and somebody that does this work is that it places individuals at the center of this science, right? They just in the same way they're experts in their own lives and get to control the services they get, the programs they're a part of or should, it allows them to co-create the science about their experiences in their life rather than some, again, ivory tower authority and power being how this is rolled out. And it's a key element as we just as it is in recovery support services to how we engage in the science. Sorry, I had a pop-up come on my screen. So if we think about this, right, and we'll hear about this over the coming months as we get into think about what is recovery science really worried about outside of from a theoretical perspective, and it's the orientation of the research, right? So we're much more interested in longitudinal or multi-time point data collection spanning years, not months. 90 days tells us very little. We have to look at a diverse array of interpersonal and intrapersonal outcome measures, and these can be flexible and should be informed by the people participating and who their studies are about, but things like recovery capital, human flourishing, self-esteem, self-efficacy, stigma, hope, lots of different measures that are certainly more than just recovery capital, but what you necessarily won't see is things like percent day abstinence or analysis. Those are old mechanisms and endpoints from a different frame of reference of how we conduct research. And all of this should be community-based participatory research from a methodology standpoint, meaning that people in recovery are not only part of, like in terms of advisory boards, or like, hey, we're going to come study you at your RCO, but they're actually involved in the research itself from inception to publication and everywhere in between, including dissemination. So it's no longer just leveraging and tokenizing people with experience, but actually including them in meaningful ways in that research itself because they have the best insights to it. And mixed methods, when possible, across studies should be a central tenet of this as well, both qualitative, so listening and analyzing people's stories, experiences, what they tell you, as well as quantitative research as well. It should include both when and where it can as a priority. We'll skip over this one, and as you read through it, it really begins to get more. And I think the two takeaways, if you're listening to this and trying to frame it, these two are the most important because they will inform the outcomes tools that you use, the methods for collecting that data in terms of endpoints, but community-based participatory research and mixed methods, both listening to people and centering them within the process is key to recovery science. If you remember nothing else from today, remember those two things as you go forth and engage in this process. And if you're a practitioner and somebody says, hey, we want to do a RCT or a study on your program, make sure they're including these in your results or demand that they do from my perspective. As we look through, I want to finish before we get into Pren, as we begin to wrap up. Again, more content in these slides as you review it afterwards. But we have this a long history of formal recovery support services, and I chose RCOs because it's where most formal recovery support services are happening today. And RCOs have a long history, if we really go back, of how they came in our country, right? And they really are a byproduct of these informal mutual aid recovery support services, from 12-step clubhouses to Wellbriety groups, Oxford groups. And the new recovery advocacy movement over the last 20, 25 years gave way to more formal supports that we would consider RCOs, really embracing this idea of many mantras that you probably heard before, which is multiple pathways of and to recovery. And it's today in 2023 is where most outcroppings, whether those are traditional RCOs, collegiate recovery programs, recovery high schools, et cetera, where most formal peer supports, recovery housing as well, are delivered. And they're all based in similar frameworks. It's important, like, we have to know our history, right? The peer movement that is centered in where these spaces are operating out of has a lot to owe to a lot of other different fields, including HIV and AIDS and the mental health fields. The anti-psychiatry movement is a huge one. Nothing new is really ever created in life. It's just reconfigured and remade. And these idea of the peer movement, mutual aid communities, and advocacy gave us RCOs as we know them. The more formal ones were really founded sometime around 2000 in our country. The summit to Minneapolis is that was paved the way from all of this work, all of this history, as well as SAMHSA funding and access to recovery and RCPs, et cetera. And all of these have these same underlying principles similar to recovery science. These are community-based, peer-created, and peer-led. They're not clinical, nor are they created by outside entities. They're created by community. People with lived experience are centered in these frameworks where these services are largely delivered. We think currently there's 3 primary models of RCOs around the United States. These are traditional RCOs that you probably have interacted with most. They're created by the community and focused on providing peer-based services. Hybrid RCOs, which are traditional RCOs combined, these are more recent, with elements of peer-based harm reduction services as a full continuum of care, but still created by the community. And then over the last 20 years, we've also seen a lot of these, which are quasi-RCOs, which are created by outside entities, whether they exist and are funded by treatment programs or governmental entities, et cetera. And they may or may not have community involvement and may or may not employ peers used to their full capacity. And it's important to know where the services that are being studied are being looked at and how they're delivered and which model they may come from, because they have different pros and cons at any given time. Current RCO models is, we have a paper around this as we've really been to explore and identify different types of community organizations and models and the core services they may provide. Hybrid RCOs, again, being an amalgamation of 2 different sides of that field, which we're seeing more growth now, I think, than ever before. Great paper on rebel recovery, if that's a new term for you, hybrid RCOs and where these types of recovery support services are being delivered out of Florida. Would certainly suggest looking it up. Provides even a strong empirical basis at this point of how to engage even some of the most underseen populations in our communities, which is I think an organizing paradigm for many of us in recovery support services in the landscape. So as we take all that together, what do we need to know about it? And many of you already do. Non-clinical, non-clinical, non-clinical. Recovery support services, as we conceptualize them here, is really non-clinical services, predominantly delivered by certified peers, but can be volunteers, that leverages those same things we talked about prior, that co-equal power dynamics, leveraging lived experience with training and education and ethical boundaries to help people explore their own wellness and health and well-being. We have found that predominantly in that delivery, that recovery and wellness planning is the primary mechanism of delivering that support in a variety of engagement channels. We also find, as we look at these, right, and these are things we still need to know more about, that supervision is predominantly delivered in 2 primary ways: peer supervisor or behavioral health professional. We have some emerging best practices within those, depending on the type of funding, Medicaid versus something else, perhaps. It can take a variety of forms or what's required for that funding source. And we do think that supervision should be individual plus group monthly at a minimum within that, as well as exploring from emerging recovery science research on this of how, in terms of practice guidelines, which is another outcropping of translational research, how to do that well and support this workforce that we're seeing deliver recovery support services more than anything else. We have covered all of these. There's lots of different ways in terms of characteristics of how RCOs may manifest. They're not all just community centers or how they manifest, but as we begin to transition into PRIN, we still don't know a whole lot about, again, what we think is the most common recovery support services delivered by peers. We have now the largest PRSS data set that's been amassed within our field using a recovery science framework, actually working with RCOs and people delivering these services across the US. And it begins to answer you all. I think we all have this question, right? We know in our hearts, right? We know, and because many of us have experienced this, that peer services work, that recovery support services work, but empirically data is sparse, right? We have a couple of studies from Dasuke and colleagues around a systematic review in 2016 around the efficacy and outcomes of and effectiveness of peer services. We did find some positive, or they found some positive outcomes from that, but most samples around this are quite small, right? It doesn't necessarily answer the question, which is why we have sparse data of do these things work and for who? And now, over the last couple of years, we're beginning to get a little closer into that with larger samples, larger impact of services, a larger standpoint of answering predominantly that question for who and where. And if we look at that, again, from where we're at today with emerging recovery science is improvements in recovery capital is operationalized as a primary outcome in recovery science rather than things like, again, percent days abstinence, et cetera. We do see statistically significant improvements for peer services delivered at RCOs across the country. And we also find that if we look at what actually impacts those things, the mechanism of action, if you will, that can actually predict improvements in recovery capital, we might find things that would make sense, right? About people tell us from qualitative interviews that how often I see my peer and the intensity of that matters, as well as the progress I make on my self-identified recovery plan goals. More progress, building more recovery capital makes sense, I would imagine, naturally for those of you in the field, but it begins to verify what people are telling us that actually do this work at RCOs and more broadly. So the ultimate answer is we set this framework of do these things work? We think so, but we still need to know more, right? It's this ever-endeavoring quest to answer more questions, which is the purpose of this ECHO, and hopefully for many of you getting involved in recovery science, because we have more things to answer, and we finally have a framework to do it on our own terms, with our own communities, in what we consider perhaps a more authentic way that believes and belies what recovery support actually is. So if we move forward as I begin to wrap down, why are we all here is really around PRIN. There we go. So the Peer Recovery Innovation Network is a funded R24, and the idea is to build research capacity for current and future recovery-related topics and provide training for those recovery scientists, postdocs, people and practitioners, why you're even here at this ECHO, to really push that forward for the next 20, 30, 40 years. Our primary aims at PRIN, the first, which you are all now a part of, congratulations, is the Recovery Science Collaboratory, which is looking at bringing together stakeholders in a variety of ways to talk about and learn more and learn from each other about recovery research, about the things existing in the field and how we can continue to push that field forward. Also more intensive in aim 2 around looking at recovery science training and mentoring. Our new postdoc at PRIN, Ducel, is actually on the call. Hopefully you can wave in the chat, but really beginning to think of emerging scientists and giving them the training and skill sets through a lens of recovery science, so that we have more scientists coming up after us to continue to push that field forward as well. And as with many good grants, aim 3 is evaluating the work that we're doing, getting it out to the field through dissemination, and sustaining that work so it's not a one-time effort. If you're interested, our organizational structure at PRIN, we have a heavy involvement from outside stakeholders, people with lived and living experience, professionals, researchers, scientists, because we like to practice what we preach. So we have an external advisory board of all of those stakeholder groups, including people who actively use drugs. We are part of CORES, which is all the funded R24s. If there's anybody from any of the others, I would love if you put your funded project links in the chat for people that may not be familiar. And we have the Collaboratory, which again, you're all part of now, which is stakeholder groups coming together to learn in a variety of ways. And then our aim 2, which is all the future trainees and mentors and mentees that we'll have as part of our project as well. If you're not familiar with it, our AAB, they meet 4 times a year, and their idea is to keep us honest, if you will, in an informal way around the work that we're doing and the progress we're trying to make. And then our Center Without Walls, again, that you're all part of, is this informal group meeting in a variety of ways and shared learning. And that will change every month. The ECHO is one of those things. There will be lots of other ways to engage in our process as well, including one that's going to come out fairly soon, which is helping us to identify a core research agenda as step 1, which will come through a survey that we're pushing out to the informal and formal recovery support services field, so that we can actually, as we begin to give out money for pilot projects, where should we be focused our time, attention, and resources? What topics are important to the community? What should we be researching? Where should we be creating collateral? Where should we be putting resources? And I hope all of you will continue to provide us that feedback, because we need it. a few of the other things that we're making available that will help push our field forward. So unique data sets, these idea of de-identified recovery support services data en masse across the country, making those available for researchers and for secondary analysis and other means, getting data into the hands of people that can help push our field forward. And then also creating different both research and practice-based resources around recovery science and research and peer services explicitly to get those in a repository so that people can access them to begin to deploy them in their programs, their services, or their research over time. I did mention funding, and for those of you that are researchers, please be on the lookout for this as we finish our research agenda setting. We will be giving out pilot funding to start doing emerging research and recovery science for priority topics that can be used and leverage itself for additional funding in the future. Should expect that in early 2024, but that is perhaps one of the things I'm most excited about. And for training and telementoring, the ECHO is part of that. More broadly, we are also looking at additional objectives of certificates in recovery science, our Texas Substance Use Symposium, which I'm sure one of the staff members from BeWell will put in the chat so you can register for it in February of next year. The idea, again, of creating a broad array of network and infrastructure to help educate people, this ECHO, which is part of that, and one mechanism to do so. And aim 2 on this telementoring, which is done, we have our new postdoc. And again, would like to welcome Ducelle to this project and continuing to push this agenda forward. And finally, led by Daniela, who's on there, is we want to evaluate everything we do because we can do nothing if we don't study it, so that we can make changes over time, which is a key part of any research. And we certainly want to make sure that we're holding ourselves to that account in PREN and beyond, as any good research would. And I'm sure I'm a few minutes over, but thank you all again. I'm happy to answer any questions if we have time before we get into the case study. But hopefully there's some things to think about or some context to be helpful as we launch this ECHO and move forward into the next year.
Thank you so much, Dr. Ashford, for this amazing presentation and for setting a stage for this ECHO series. In the interest of time, I guess we can take maybe a couple of questions. I did see one in the chat from Jason. How does the prevalence data break down when we overlap SUD severity over it?
Yeah, I think they're great questions. Pulling into, I would highly recommend reading out to Dr. John Kelly or Bettina Hopner or Brandon Bergman at the Recovery Research Institute, who owns that secondary data. I don't know in the crosstabs of that data in the published body, or I know they have it, but I can't answer it off the top of my head. And looking at it, I think it's a great question. If it's not there, it's certainly something that we need to begin to explore, and looking at acuity and looking at how we further define that from the macro down to the micro.
Thank you. With that, we will move on to announcements. Maria, if you could please share the announcements. Thank you so much. And thank you again, Dr. Ashford, for the wonderful presentation. The Center for Substance Use Training and Telementoring provides high-quality education and best practices for responding to substance use. CSTAT can help enhance professional knowledge and self-efficacy to screen, treat, and make referrals for people with substance use disorders. To learn more, please visit us at cstat.yadisca.edu. Next slide. To claim your CME credit, you must text by midnight tonight. Please text attend 1009-5044 to 844-502-1338. Next slide. Our next Recovery Science ECHO is on Wednesday, November 15th. Please do join us. Thank you so much. And with that, we will move on to our case. Maria, if you could please bring up the case, and Dr. Hennessy, if you could take it away.
Great, thank you very much. Yeah, so I think this will be a brief kind of description of the case as an example. You know, as a hub member, I thought this case might be a nice example for others to see. It is a historic case example. If you can just kind of like scroll up a little bit to the description, that would be great. So this is a previous study that's already been completed. It was funded as a 5-year grant from NIH, and I was not the PI on this study. This was actually when I was in graduate school, and it kind of launched my research career in examining youth substance use disorders and treatment and recovery and all the things that go along with that. And so I think, you know, what Dr. Ashford really nicely alluded to is that there is a lot of anecdotal and descriptive kind of evidence for the effectiveness of recovery support services in a variety of areas, but less empirical research. And so this study was actually to examine the effectiveness of recovery high schools for young people who were involved in resolving a substance use disorder experience. And they've been around since the 70s. But, you know, there hadn't until the time of this study, there hadn't been a study to examine their effectiveness. And so one of the reasons I wanted to bring this case to the group is that I think there are kind of lots of challenges in working in this space where you can't necessarily assign folks to attend a certain type of school, like a recovery high school. You know, families would be outraged if that were to occur. And similar, I think, to other recovery support services, we can't tell people as part of a research study design, you know, attend this versus attend that typically. And so there are a lot of challenges to kind of working with young people and their families and recruiting them into a study like this, and then also working with them to keep them in the study over time, that I thought would be interesting to this group. I'm sure many of you have come across this in your own work, just around, you know, how to work with families and young people to examine their participation in recovery support services, and also how to think about, you know, all the different outcomes that you would hope to see in someone's life as a result of engaging in your service, and being able to say that, you know, what we're doing is contributing to that effectiveness, to those positive outcomes in somebody's lives. And so some of the things that I thought were really unique about this study were just some challenges in ensuring folks wanted to be part of this study and then keeping them involved over time. And then also kind of being thoughtful about the types of things that we were asking of participants to share with us, to collect over time, getting enough research information from them without overburdening them with questions, but still being able to answer that key question of, you know, are recovery high schools effective for youth who choose to attend them? And you know, what sorts of youth might benefit from those schools versus kind of other recovery supports. And so those are just kind of some of the basic kind of underlying framework for this study. There are a variety of publications that have come out of this work. Dr. Andrew Finch is one of the key PIs on this study, and so if you Google his name, you'll come across you know, many of the published studies that came out of this. But there were a lot of kind of background challenges that I thought would be interesting for this group. So I don't want to take up any more time with background, but I'm happy to answer clarifying questions before jumping into the discussion as well.
Thank you so much, Dr. Hennessy, for providing a succinct summary of the case. And I'll now open up the floor for any questions or comments or anything the group wants to share.
I've got one. You know, one of the things that I haven't put much thought into, right, but and we're talking about recovery high schools, or at least in this case, is conducting research on minors, right? And I didn't realize you talked about you know, consent, et cetera, but I'm wondering, like, takeaways that you may have had, or how y'all thought about researching minors, right? In addition to consent, does it present different unique challenges? You know, I think there's certainly a mindset around kind of acuity at younger ages in terms of maturation out. Like, is it actual, you know, severe substance use disorder? What can recovery look like at that stage versus misdiagnosis? I'm just wondering how y'all thought about research with adolescents and the impact it may have had either on design overall, or how you might think, should we be approaching and thinking about research differently with that age group and cohort in the future?
Yeah, it's a wonderful question, and it is so challenging. You know, that was throughout the study. Those were all sorts of considerations for youth minors, especially because typically recovery high school students are, you know, 14, 15, 16, 17. And obviously there are institutional requirements around recruiting young folks into research studies. And, I think there's a couple competing viewpoints. So on the one hand, if you think about a young person who, is engaged in recovery support services, has a supportive family, they may want them to be part of this study, and actually engaging a parent in the consent process can help retain the participant over time. They can be someone to help you catch up with wherever the young person is. On the other hand, if you think about kind of developmentally, where adolescents are, in terms of that life stage, they're seeking independence, and they're seeking, they're really seeking to become adults, or kind of transitioning into that space. And so for some folks, I think it can be challenging to say, you're becoming an adult, but you still need your parent to be part of this research process on your experience in recovery. And so, I think some institutions handle this in a variety of different ways. Other countries, I think, go by the Gillick competency. And so they essentially say if a young person has the capacity to understand the consent process in an observational study like this, then they can consent on their own. And then other institutions are really thinking about the liability and kind of the parent perspective, and pushing back and saying, no, you really need parent consent. And so I do think when working with young people in recovery specifically, there is a need for a paradigm shift in how we think about, especially young people who have gone through a substance use experience and are working towards recovery. They're oftentimes more insightful than adults that haven't gone through that experience. So we could argue that their Gillick competency would be quite high and ready to agree to participate. So that's kind of one of the challenges I think that the field needs to grapple with, is how to deal with young people specifically in that minor guardian caregiver dynamic.
I see a question from Jason.
Hello, thank you for taking my question. It's really around thinking about recovery high schools, community centers, recovery housing. We often talk about it, the setting is the service, the milieu. And so often when we're looking at research, we're looking at a particular service, like, a peer specialist working with an individual. I think we tend to struggle with how do we capture the value of the setting itself. Any thoughts around that?
I have some thoughts, but I want to see if anybody else is gonna jump in with their experience.
I mean, I'll just quickly add, I think, John and Bettina at RI that have one of the other funded cores of looking at recovery community centers, right? And I think have published some recent work that looks to that, even, both formal and informal, or more social model of recovery support versus formal interaction with peers, have begun to tease some of that out directly, right? I think that the question will always come from an empirical nature, is how do you operationalize even the informal setting, right? Is it around frequency and duration? Is it about involvement in a variety of informal activities in that setting? And I think that continues to be the struggle, at least from my perspective, is how do you operationalize the setting and actually study it in terms of its impact on the individual and outcomes that are important to them or to that study. I think we're beginning to see some of it that really begins to tease some of it out, but I think it's early days. But I agree, right? Setting is critical to what we see this happens. It's not just always the formal service.
Yeah, and kind of along those lines, like, I don't think we've pulled enough from community psychologists in thinking about how to measure, the social climate of recovery residents, for example, and kind of getting at the social milieu and how comfortable people are in these settings. And in some of I've worked with Angie Nash and some of her ethnographic data of alternative peer groups. And, some of the young people she worked with were a part of an alternative peer group. And when they started in that group, it was a really unhealthy environment, and they left because they said, these other people, they're mean to me. I don't want to be part of a group that's mean to me. That's not the point of, recovery, engaging in this service. And then other young, it was kind of an ebb and flow, and other young people did feel really connected because it was a safer environment. And so I think we need to do a better job of understanding how to measure that kind of overall kind of social climate, if you will, and setting.
Thank you. I saw Pastor Deb, you had a comment to share.
just quickly, and I want to emphasize this comes from the faith base, that our outreach and engagement for grief and recovery includes adverse childhood experience, expertise, and must always include family engagement. Many of the children over here and teens experiencing recovery need and experience are having the family issue of origin where the parents are not going to agree to any recovery because they themselves are resisting. I just wanted to throw that out, that the faith base gets triangled into the school systems and the community base, but we really try to stick with the family engagement because you scratch the surface when you deal with these children in a school setting. I just wanted to offer that. Thank you.
Thank you so much. Anybody else would like to add a final comment before we move on to summarize the session?
So for as far as the recovery housing setting, I mean, like there's so many recovery housing softwares that are out there that, you know, go from the team down to the resident, and all of them miss the mark. Not one that I've seen yet, you know, captures enough data to be able to show what people are like in that environment, how they're enjoying it, how they're succeeding, and what the outcomes are.
Thank you. In the interest of time, Dr. Ashford, if you could please summarize the case and for us.
Yeah, happy to. And Emily, I'll apologize in advance for if I bastardize your very important research, but generally in this kind of post hoc review of looking at conducting research with minors in recovery high school settings and both effectiveness and efficacy, really looking at challenges around how are we measuring it, looking at challenges of retention and engagement and minors as our first case study within recovery science, which is an interesting one. And I think, you know, some highlights from the conversation that I think, which is really around, hey, what do we need to do more of? What do we need to continue to tease out and consider within this research? So first and foremost was around engaging different subjects or participants, in this case minors. How do we engage them ethically and meaningfully in this research, and does that differ of how we might engage in research with other cohorts or other milieus? And then I think equally as important is this idea of teasing out across the range of recovery support services, looking at a formal intervention or formal service like meeting one-on-one with a peer or meeting with a mentor, guidance counselor in a high school perhaps, versus the setting themselves as being the social setting of service and the impact that it has on outcomes that may be important, whether they're moderators or mediators. And then certainly looking at, I think more broadly, is broadening our perspective of who we include in research, different perspectives like family members or ACEs, and then also the tools that we use to collect data. From Slade's last point of, you know, the research is only as good as the data we collect and how that's analyzed, and the tools that we use have to continue to mature just as much as the research does. But a good first start.
Thank you so much. And thank you all again for joining today's inaugural session. As a reminder to earn CME credits, please complete the post-session survey using the link in the chat. Please text the code by midnight tonight. The code once again is 10095044. If you'd like to present a case, please email the BWell Texas team at bwelltx@utisca.edu. We look forward to seeing you on our next session on Wednesday, November 15th at 12 noon Central. Thank you and have a wonderful rest of your day. Bye-bye.